count, so. Okay. Okay, I think we're ready to go now. So, welcome and thank you everybody for attending the final FASD learning session of 2014 and 15. This series is part of the Government of Alberta's 10-year plan to address FASD, or Fetal Alcohol Spectrum Disorder. Today, Dr. Jackie Pye, Marnie Hutchison, and Katie Wiper will be presenting on what's new in FASD research. Before I introduce our presenters, there are a few housekeeping tips. You can ask questions during the presentation by using the question and answer module on the right-hand side of your screen. A session facilitator is monitoring the questions and will pose them at suitable times during the presentation. If we aren't able to answer all of the questions during the live presentation, we'll answer them via email after the session is over. It's important that you include your email address when you ask a question, otherwise we'll have no way to respond to you. In order to receive your certificate of attendance, you must have signed in after 8:45 a.m. Mountain Standard Time. Evaluations for the session will be emailed to you after the session. Please complete them. We rely on your feedback to continually improve what we do and how we do it. Today's presentation will be posted for viewing on the Government of Alberta website, fasd.alberta.ca, within 2 weeks of today's date. If you experience any technical issues, please email support@cmgcanada.ca. Also, please let your local tech support know, as the problem may originate on your end. As Alberta advances with the FASD 10-year strategic plan, education and training continue to play a key role. This is our 6th year of offering sessions and our 3rd year of delivering the material as webinars. As always, the sessions are recorded and made available on the Government of Alberta website, fasd.alberta.ca. We are pleased with the ongoing interest and attendance in this initiative. And I now have the pleasure of introducing our speakers. Catherine Wiper is a doctoral student in the Department of Educational Psychology at the University of Alberta. Her research and clinical interests focus on neurocognitive factors that relate to high risk and criminal behaviors in youth and adults, and she has a particular interest in fetal alcohol spectrum disorder. Marnie Hutchison is a doctoral candidate in the School of Clinical Child Psychology program at the University of Alberta. Marnie's doctoral research is investigating the efficacy and feasibility of group-delivered attention and working memory training in schools for children with FASD. During her studies, Marnie worked with the Glenrose Rehabilitation Hospital Adult FASD Assessment Clinic as a psychometrist and project evaluator. As part of her clinical internship, Marnie worked at the Lakeland Center for FASD. She's now at CASA conducting psychological assessments to inform therapeutic and educational intervention. Dr. Jacqueline Pye is an associate professor in the Department of Educational Psychology and assistant clinical professor in the Department of Pediatrics at the U of A. Also a practicing registered psychologist for the past 12 years, Dr. Pye began her career as a criminologist and forensic counselor working with incarcerated youth. Motivated by this early work, she returned to academia to study youth at risk, child development, and neuropsychology, leading to her current focus on interventions for individuals with FASD. Building on her work with community and government agencies, Dr. Pye currently leads the Intervention Network Action Team for the Canada FASD Research Network, a role that facilitates the link between research, policy, and practice. Please join me in welcoming Katie, Marnie, and Jackie.
Fantastic. Thank you, Nicole, and thanks everyone for joining us today. We're looking forward to talking to you a little bit about what's new in research in the FASD world. So as you heard, joining me today are Katie and Marnie, and I was once told early on by a trainer that when you're doing your training, when you're doing your school, when you're doing your work, there are 3 really important messages I can give you. Work hard, study hard, and more important than those 2 things, surround yourself with people who are smarter than you, because they'll always make you look good. I've done that, and you're going to get to hear a lot from those 2 ladies today as they talk a lot about the research. So they're going to do the hard work. I get to come in, say hi, introduce myself, introduce them, and tell you a little bit about what we're up to, and then I will help kind of wrap things up. So essentially, the objectives today, what we hope to accomplish, is to have these fantastic women take you a little bit through some of the research and the research that's come out largely, I think, in the last year. You guys sort of focused in the last year. So this is pretty cutting edge. This is the stuff that's been published in the last year. Then we're going to talk a little bit about what does this mean in terms of application? Because we hear a lot about the research. We can talk about what's happening in the labs or what's happening in a study. But then oftentimes the translation or the meaningfulness back to what we're doing in the community isn't clear. Or we're saying, well, that's a great research idea, but how does that help me do my job on a day-to-day basis? So we'll have that conversation after they've presented some of the research. And then we're going to wrap up by talking a little bit about what next and how do we propel the field forward. And when I think about FASD research, one of the things that I think is really important for us to keep in mind is that oftentimes practice, the work you guys are doing in the field, is actually what's driving the research. Because our practice in many ways is more advanced than our research. Research takes a long time and is slow. The demand in the community and the need for these families, children, adolescents, and adults is high. And for that reason, we're responding and we're flying by the seat of our pants. And so a lot of times, even the research we conduct in our lab is informed by what is going on in the community. And folks are saying, hey, we're running a program, we'd kind of like to know how it's working or what we could do to enhance it. And so we end up having these lovely conversations between research and practice to say, okay, well, here's what the research says. What are you doing in practice? Okay, we'll do some more research around your practice, and here you can try out some of the things we found. So we all end up being part of the same team. And as we sketch out the future of research in this field, I think the more we can do so in conversation, the better and the more meaningful the work that we're going to come up with is. So I guess, interest of deferring all responsibility for anything, like I like to do, just ask these guys. I encourage you all, as you're listening to these ladies talk, to really think, okay, where is the value in this? How meaningful is this information I'm hearing? How could I use this in my practice? How can my practice help advance the way we're thinking about these things? Because then when I come back to the mic, I'm going to say, all right, here's some key themes that these ladies talked about. Here's some key practice ideas. And then I'm going to invite comments, questions, and thoughts from you folks in terms of what you see and ideas you have and questions and ideas that you think are important. And that's just so that I realize there's a large group and it's tough when we're dealing with multiple sites. But even at a site, if you've got a number of folks at a site, you might say, hey, let's ask her what she thinks about this or how this would work or how this particular research area that these guys talked about might be relevant to us. And so I encourage you at your sites to kind of jot down a couple of notes, and even if you come up with some site-based questions that we can then sort of think about how we apply this research and inform the research moving forward, which is really the goals of the presentation today. At the end of the day, we're wasting our time doing research if it doesn't change the way we do practice. So if we can't figure out how to put it all together, then what are we doing here? And so that's really our goal, and something that's pretty important to me is how do we put it all together at the end of the day? So I think that's enough for me to begin with, more than enough for me to begin with. And I'm going to let these guys take you through some of the new science and the new ideas out there. And then we'll return to some of the practice. In terms of questions as well, if you want to hold some of your questions, if you have specific questions about studies or things that you're hearing about, hang on to them until the ladies are done. When I come back, then you can throw them in, or throw them in, and maybe Nicole or whoever's monitoring questions, you can hang on to them. And then when I come back, we'll open it up a little bit, because I tend to be a little bit free form anyway, so we'll let folks direct some of our conversation as well if there are some questions that come in after these girls are done. So send them in, and we'll do a bit of that when I return to the podium that I am supposed to stay standing behind. Look at me standing still today. This is very hard for me to stand still. For those of you who have ever seen me speak, you know this is really hard. I'm actually having to hang on a little bit right now, not moving. All right. So Katie is going to start us off and take us through some of this science.
Thanks. Good morning. So as Jackie said, Marnie and I are going to run through some of the research that's been published in the last year and a half. We actually did a scan of all the literature published in 2014 and 2015. We just used the search terms fetal alcohol spectrum disorder or prenatal alcohol exposure. And that initial search yielded almost 1,000 new articles. So we sifted through all of these abstracts and chose a few categories of different kinds of research that we thought would be most relevant for clinicians and people actually working in the field with people with FASD. So we narrowed it down to, I think the total was about 100, maybe 120. And so we're going to skim through very briefly all of those studies today with a couple of sentences each. And as Jackie said, if there are any questions about specific studies, make a note of the study that you are wondering about, and then we can send you the reference later on. So the broad categories of research that we figured would be most relevant to the discussion today are numbers. So the first category is about statistics, incidence and prevalence, costs of FASD and associated difficulties. We also found quite a few articles looking at different new screening practices, and then a few in terms of assessment and diagnostic practices. The bulk of the research we're going to be talking about today is profile. So what we mean by that is different profile of functioning, whether that's cognitive functioning, brain functioning, social functioning, so that the bulk of the research it falls in that domain. And then we found a couple of papers on intervention, and then we'll wrap up with some prevention research. So to start off, I wanted to give you guys some updated stats on fetal alcohol spectrum disorder. Now, the statistic that we've been citing in our research for the last few years comes from 2009, and it was a Canadian study that was published reporting approximately 1% of all live births. So basically 1% of all children who are born in Canada are affected by FASD. That was the stat that we were referencing in all of our papers. In 2014, just last year, there was a new study published out of Alberta looking at health records from 2003 to 2012, and they found that the incidence was actually quite a lot higher than we previously suspected. So the incidence is the number of live births in Canada, and that stat is now estimated to be between 1.4% and 4.4% of live births. So that's quite a lot higher than we were previously thinking. And then that study also looked at prevalence. So that's the number of people currently living with fetal alcohol spectrum disorder, and that estimate was approximately 1.2% of the Alberta population. That was a huge study in Canada, and then there was also a slightly smaller study published out of the States, also in 2014, and they surveyed first graders. I think there was like 600 or 700, I can't remember the exact number, but a bunch of first graders in a Midwest U.S. state, and their prevalence estimates were a little bit higher, so between 2.4 and 4.8% of the first graders were affected by FASD. And then this last study was published just recently in 2015 out of Australia, and this was in a small rural Australian community, and they surveyed just the small community. I can't remember the exact numbers, but the prevalence within that community was 12%, whether that be fetal alcohol syndrome or partial fetal alcohol syndrome. So that's just telling us basically that the numbers are higher than we thought that they were. The next thing we looked at was costs associated with FASD, and these are annual costs. I'm pretty sure all of this research comes from Canada. For sure, the children in care and the morbidity studies came from Canada. So when we look at children in care, we estimate that approximately 3 to 11% of children in foster care are affected by FASD. So that's a huge proportion of the population. And this study looked at costs associated with caring for these children. And that cost ranged from 58 to 198 million. And those costs were associated with basic maintenance. So that's things like everyday costs, like food, utilities, clothing for the children. Special needs were above and beyond basic needs. So that's things like doctor's appointments. And then exceptional circumstances were, again, things that went above and beyond basic maintenance or special needs. So things like legal fees if a child got involved in the legal system, or one of the examples was one of the children living in a foster home needed a ramp built at his house because it needed to be wheelchair accessible. So anyways, the overall costs of caring for children with FASD in the foster care system was quite high. The next study we looked at had to do with speech and language intervention. So a lot of children with fetal alcohol spectrum disorder experience speech and language difficulties. And so the costs associated with supporting these children the estimates range from $7.2 to $144 million per year. These are all annual costs. And then finally, this last study looked at productivity loss to the Canadian workforce associated with the challenges or the disabilities that come with FASD. And this study estimated that the productivity loss for the Canadian workforce ranges from $418 million to over $1 billion. That's how much these researchers estimate we're losing in the Canadian workforce. And specific to Alberta, that number was $88 million to $126 million. The next category of research that we looked at was new screening practices, and then also clinical studies related to assessment and diagnosis of FASD. We found quite a few studies looking at meconium. So meconium, as Jackie says, is the baby's first poop. And so researchers actually can look at the baby's first poop to tell whether there's alcohol or remnants of alcohol in it. And so researchers are thinking that might be a new way of screening for FASD and detecting prenatal alcohol exposure very early on. So there were a couple of studies looking at this practice. One of them was in Prince Edward Island, and researchers there looked at 1,000 poo samples, and they found that 3% of them had screened positive for alcohol remnants. So from those numbers, the researchers estimate that approximately 1.3% will later later meet the diagnostic criteria for FASD. Another study looked at the difference in rates of prenatal alcohol exposure when you ask the mother whether she drank versus whether you look at the baby's first stool sample. And they found that when you're looking at the stool sample, the rates that indicate prenatal alcohol exposure were over 4 times higher than maternal report. Another study looked at the long-term the long-term associations of having alcohol indicators in the stool sample. So they looked at meconium, they followed up children who screened positive for meconium, alcohol in the meconium, and found that 9, 11, and 15 years later, when the child was 9, 11, and 15 years old, higher levels of alcohol, essentially, in the poop sample was related to significantly lower IQ scores in verbal domains, working memory domains, and then full-scale IQ overall, 15 years later. So you can see that this is really interesting research. This could be really useful research in the long run, but there are also some really important ethical and social issues that come along with this idea of meconium testing. I won't go into it. There's a really interesting article published in 2014 commenting on the social challenges and the ethical challenges associated with using meconium testing. That's it from me. So Marnie is now going to just talk about some more of the screening and assessment efforts.
So while we navigate the question of looking at poop or not, other researchers have spent their time developing a behavioral screening tool. And this is called the NST, Neurobehavioral Screening Tool. They took a well-validated behavioral questionnaire called the Child Behavior Checklist and narrowed it down to 10 questions. And there's been a few studies looking at the use of this screening tool to detect whether it has specificity in identifying FASD or not. So it's I think a more practical, less socially divisive, and fewer ethical discussions around this screening effort. The reason that we need these screening efforts is because currently our pediatricians are under-recognizing FASD in their clinical practices. And so the researchers are really trying to get something out there to our community centers, to our pediatricians, to social workers, etc., to have something to do a quick screen. So early on we know whether this might be a child that we should refer for an assessment, so that we can get interventions in place sooner, because we know that is better. Some other screening diagnostic assessment efforts are focusing around our facial measurements. So as we know, looking at facial characteristics of the child or adult being assessed is a key part of the assessment. It has been for quite some time. There's a few papers that kind of showing different things right now. So we have one saying that our computer technology is overdiagnosing facial features, and then we have this other one that's saying our software is very comparable to our gold standard calipers, and much better than using a hand ruler. So probably more to come on this. I don't think the facial measurements are going away, not going anywhere in our assessments, so we will probably see some more research fine-tuning this practice. Partly because we're still seeing high rates of misdiagnosis, so missed and misdiagnosis. So we're still fine-tuning that process. Part of that fine-tuning also is getting better at the ways we're assessing all our other domains. So we assess in cognitive, academic, memory, executive function. One of the other areas is sensory motor. And there's a really neat Canadian study looking at using robotic technology, looking at sensory motor skills, because it can be much more sensitive and specific than the standard assessment tools that our occupational therapists or pediatricians are using right now, that are more in the flesh, gait and walking and things like that. So we might be getting more sensitivity with this robotic assessment. Another new or novel assessment practice that is being published in the literature is this telehealth kind of assessment. So we have a lot of diagnostic clinics across Canada doing really excellent work, and I think a number of them are doing telehealth services. A group in Manitoba has published on their telehealth practices in assessment and diagnosis, and reported on the family's experiences going through this, their satisfaction with the process, how it felt for them, what it was like doing it not in person, and they actually had very good reports that it was a good experience for them, and they had satisfaction with it, and that it met their needs. So we're seeing that that's perhaps a promising way of delivering services to our youth and families and adults that aren't near a center with a diagnostic clinic. With respect to our diagnostic guidelines, we have new ones on the way out of Canada, which is very exciting. So although they aren't published right now, we'll probably be seeing something soon in 2015. So be on the lookout for that. And part of these revisions to our guidelines, like I said, is the facial features, narrowing in on our domains. In South Africa, they've been doing a little bit of research on the lip and philtrum measurements, looking three-dimensional rather than just straight on, so just fine-tuning. Like I said, we have some really excellent clinics doing really great work across Canada and in the world. And in Southern Ontario, we have a clinic that is doing adult assessment for FASD. And they publish on basically their clinic processes, how things are going for them, their numbers. And I think the key things that Katie and I wanted to pull out of that study was the issues unique to adult assessment. So the adult teams have really had to learn from our child teams and adapt as they go. It's been a bit of a new venture for them. And some of the issues that they're finding in this clinic are, as you see, high cancellations and no-shows. Getting that background and historical information 20, 30, 40 years ago when those records have been destroyed is a big barrier for them. And alongside that is obtaining that maternal alcohol history. For adults, as it can be for children, establishing those collaborative relationships with community partners to get services in their lives is a challenge. And just finding those follow-up services. Our adults, they're not in school anymore where we can train our teachers to help them. We need to really build services around them in the community, and they're just finding that to be a challenge. So I sped right through that. I'll pass it back over to Katie, and I will see you again soon.
Excuse me. All right, thanks, Bernie. So, as I mentioned, the bulk of the research that we identified as being really clinically useful was basically falling under this umbrella of the FASD profile. So, a lot of the research that's going on right now, we know a lot about FASD, we know a lot about the difficulties that are experienced by individuals with FASD. A lot of these difficulties overlap with other populations, and so I think that one of the main things that have been going on in 2014 and 15 is kind of, as Marnie said, with the diagnostic process, trying to hone in on the difficulties or the challenges of the impairments that are specific to the FASD population. So there were a couple of studies published looking at nutritional intake and eating patterns, I guess, in both children with FASD and mothers of children with FASD. So one study published looked at rates of overweight and obesity in adolescents with FASD, and they found that particularly in females there are significantly higher rates of overeating and obesity in these youth. Another study looked at the eating and feeding behaviors of children with FASD, and these researchers noted that, again, there are a high number of problematic eating behaviors. So that was things like, constant snacking or consuming high levels of sugar, lack of appetite, lack of being full, so lots of problematic eating behaviors that could be related to this obesity or an overweight issue. As well, in that same study, the authors reported that a lot of the children with FASD are below the recommended daily amount recommended for a lot of important vitamins and minerals as well. So then another study looked at mothers of children with FASD, and they found that mothers of children with FASD were intaking fewer important nutrients than mothers who had children without FASD. And actually an interesting association was between lower intake of these key nutrients and heavy levels of drinking. Then there was this really interesting study. It was a review, and it was a review of animal research, but it's still pretty cool that researchers are looking at different nutrients that mom can intake while she's pregnant to help alleviate some of the symptoms that are later associated with FASD. And there weren't any massive groundbreaking findings in that study, just that they're saying that this is a potential area to look more into, and more research is to come, especially in terms of translating rat research into human research. I think that's a step, but anyway, it's an interesting avenue that's going on. The next category of profile research is this health and medical functioning research. One study in Detroit looked at the hormone levels in adolescents with FASD, and they found that adolescents, both male and female, had higher levels of testosterone than children or adolescents without FASD. But they found that there was no difference between the groups in terms of what stage they were in their puberty development, and the age at menarche for female adolescents was the same in both FASD groups and the control group. One small study out of Italy looked at comorbid cancer and FASD, and like I say, it was a small sample, but they found that there are certain types of cancers, in particular neuroblastoma. The incidence of neuroblastoma in children with FASD is higher than the incidence of that particular type of cancer in the general pediatric oncology population. Another study just looked at different types of seizure disorders and epilepsy in children with FASD. Again, that was a really small, I think that was only 13 kids in their sample, but it's just interesting to note that this research is getting more particular. We're looking at more the ins and outs of these different patterns of functioning. And then the last study we read about was looking at the alterations of the HPA axis. So the HPA axis, the hypothalamic pituitary adrenal system, is a fancy word for a person's stress system. And it's also related to cortisol levels. And so we know that prenatal alcohol exposure impacts the HPA system. And some research is looking at children who are I can't remember the age of these children. I think they were early adolescents, maybe 9, 10, 11 or something like that. And these researchers found that the alterations in the HPA system are long-term. They last for a long time, despite efforts for intervention even sometimes. There was a huge amount of studies published on the cognitive or the psychological profile of people with FASD. And again, I'm going to just speed through this stuff. So if you guys have questions about more specifics of the research, just let us know. So we're looking here at attention profile, adaptive functioning profile, and neuropsychological functioning in individuals with FASD. One of the studies that we looked at suggests that having a parent report, so having that parent say, these are the behaviors that we have in the home, these are the issues that we're experiencing, that offers unique information about that child's neurobehavioral functioning, above and beyond what we can detect on neuropsychological tests. So the important piece there is that the parent report or caregiver or even a teacher probably, just a person who knows the child, they can give very, very valuable information about that individual's functioning above and beyond what we would get from formal testing. Another study looked at the attention profile in children with FASD, and attention is known to be an area that's often impacted in people with FASD. But this study found that although kids with FASD had weaker attentional control and shifting attention skills, they were better at selective attention. So it's really important to recognize those strengths as well. Another study looked at the impacts of binge drinking. So when mom binge drinks during pregnancy, later the child, some of the children experience higher levels of hyperactivity and impulsivity and lower academic scores, and this applies for both males and females with FASD. There's also a lot of brain research, which I'll be talking about in a minute or two, but in particular, one study looked at, there's a typo there, cognitive and MRI studies comparing ADHD and ARND. So they're just looking at the difference in brain activation patterns, and we're finding that there are different brain activation patterns in kids with FASD and ADHD. Also, this other interesting study looked at what happens when a child is exposed in utero to maternal tobacco consumption, environmental, so even when the dad smokes, and alcohol exposure in utero. So this study found that when a child is simultaneously exposed, or when a fetus is exposed simultaneously to both tobacco and alcohol, that increases significantly the risk of later developing ADHD. A few more studies looking at learning and memory among children with FASD. This is probably not new research, but it's adding to the existing body of literature that shows that memory is often impaired in FASD. But this one study looking at the verbal learning and memory pattern, it's a unique profile compared with other children. So we know, again, as I mentioned, we know that these are areas of difficulty, but this research is looking more deeply into what those patterns look like. Again, math scores. Children and adults with FASD are known to often have difficulties with math ability, and this research is showing that spatial processing among children with FASD is associated with math scores. And again, just confirming what we know to be true, prenatal alcohol exposure is associated with poor math scores, and this is over and above what we would consider appropriate for general intellectual functioning. Lots of studies published in 2014 and 15 looking at brain function, so MRI research, tons and tons of studies. I think probably maybe about 20 of them. This research is finding that compared with control children, the volume of the brain is different in children with FASD. As well, cortical thinning, so the gray matter in the brain relates to a lot of different behaviors and cognitive abilities, and we're finding that the way that the cortex thins as we age is different for children with FASD. Again, with the cortical part of the brain, where one of these studies found that higher levels of prenatal alcohol exposure relates to less complex cortical folding. So basically that just means that the brains were less folded in children with high levels of prenatal alcohol exposure, and that was the case even when we look at a brain that's the same size. So it's less complex, and that means there's less surface area in the brain. We also found research talking about the brain domains that are accessed in children with FASD when they're completing complex tasks. We found that there are differences. So children with FASD tap into different parts of their brain when they're completing complex tasks. I think that's important clinically because I think that if we recognize the strengths and the learning differences of people with FASD, we could help better understand what their needs are and provide them with supports that are different than supporting a child who doesn't have FASD. This interesting trend in white matter. So in general population, an increase in white matter does not necessarily relate to high cognitive functioning, but it does in FASD. So there's something unique about the white matter in children with FASD. We know that adolescents and adults and children with FASD struggle with inhibition, and so this one brain imaging study looked at the effects of prenatal alcohol exposure on response inhibition in adolescents with FASD. The last two studies looked at animals again, and I thought this was funny that one study reported impaired executive control in mice because I never thought mice would have executive functions, because those are quite high-level skills. What they looked at was maladaptive perseverative behaviors, so behaviors that a mouse keeps doing even though it's maladaptive, so they considered that to be executive control. So mice who are prenatally exposed to alcohol showed significant impairments in those executive control functions, and the important piece of this is that those difficulties persisted into adulthood. Finally, again, the HPA axis, which I mentioned before, some more animal research is finding that the HPA axis is altered in mice. Not surprising, because we know that's the case in humans as well. But the cool part about this study is that there are gender differences in the HPA system for mice who are prenatally alcohol exposed. Eye movement studies. So I'm not sure if any of you guys are familiar with these eye movement control studies. They are very, very cool studies. I've never seen a child be tested in one of these studies, but I know that they have these big apparatuses that they put on their face, and they put a display in front of them, and then they track how quickly their eyes can move. And really neat research linking this clinically, showing that eye movement control in kids with FASD relates to cognitive function. So psychometric tests that measure things like working memory, spatial processing, what's the other one? Inhibition. Those skills are associated with eye movement control, which is very, very cool. This eye movement research has also been linked with brain imaging, showing that eye movement is related to inhibition deficits, but it's also related to a unique pattern of brain development, or not brain development, sorry, connections between the two hemispheres of the brain. So all of these things are linking together, and I think the important piece from the eye movement research is that it's just another indicator that helps us to understand the profile of functioning in kids, and I think it's very cool that eye movement can be linked to actual cognitive functioning. One study published looked at gender differences in patterns of eye movement, and they found that there were significant gender differences in kids with FASD. Lastly, before I step down, there was one EEG study looking at pattern of brain, I'm not familiar with EEG, but pattern of brain activation. And it showed that kids with FASD use more of their brain to complete complex tasks than kids without FASD. So one of the studies I mentioned before showed that kids are using different areas of their brain but to complete different tasks. But this study showed that they also use more. So they're using different areas of their brain, and they're using more parts of their brain to complete complex tasks. All right, Marnie's turn.
As I was listening to Katie talk, I was thinking that, previous years of research told us, yes, there's response inhibition deficits, or there's memory deficits, or math, but the studies that she was describing are really talking about how, and they're digging deeper, as she said. The same kind of thing is happening in our more social domains. So generally, I think we say kids with FASD have poor social skills, but the new research is telling us how and when. The first one, talking about playfulness, we're seeing that our little kids are playing differently in grade 1 compared to their peers. So that tells us that maybe early on in daycare, kindergarten, grade 1, grade 2, we need to get in there and model and coach them these play skills to get them on the same page as their peers, because we don't want them playing in a way that is setting them up for poor friendships and things like that. We're also seeing, the emotional withdrawal and decreased activity in infants. So this is telling us precursors and, how their social skills are different. That last one about complex social cognition is a really quite a big study looking at theory of mind. So whether you can step into someone else's shoes. Kids with FASD have a really hard time with that. Maybe that's why they have a hard time maintaining their friendships, because they can't see it from their friend's point of view or their perspective. Things like empathy. So that's really important for friendship skills. Now that we have these studies telling us where and how the social skills are lacking, then we can develop the right interventions for them. Just, building on that, research that Katie's really familiar with is the psycholegal abilities in young offenders. So if you have specific questions about that, I say ask Katie. So basically, I think what this means and what this study was doing was comparing youth with FASD to norms. I don't think to a comparison group. And they're involved with the legal system. And you know what? Our youth with FASD, they have a hard time with comprehension. So maybe when you're presenting their legal guidelines, they have a hard time understanding. They just go along with it. So they're going to get themselves into situations that they can't get out of, things like that. So ramifications for long-term for their involvement with the justice system and getting out of the justice system. Related to that, that second point is basically looking at risky sexual behaviors in adolescents. So this study found that when there was maternal drinking and high levels of it, the youth, in their adolescence, were engaging in risky sexual behaviors earlier, and I believe having an earlier first sex partner as well. So some at-risk behaviors here that, it's documented now. We probably, have known this, but we have it in writing. So, developing appropriate sexual health education practices for youth with FASD is important. The last point there is very clinically relevant for people involved in assessment and diagnosis of FASD. I think it varies, but some clinics use something called effort testing. So that's this quick little test that psychologists do at the very beginning to make sure that the client is giving it their all, that we can trust the results. Because, if we see early on that, maybe it's an off day, they're not, not giving us their all, I don't think that we have their full effort. And then if we go through with 2 days of testing, can we trust those results? Are they valid? It's a big question, I think, that psychologists face, not only in FASD, but in other worlds too. Given some of the cognitive difficulties that people with FASD have, or people who have prenatal alcohol exposure, there's this question of, when they take an effort test, are we really getting their effort, or are we tapping into some of their cognitive deficits? Can we trust these effort tests that are asking us if we can trust the results? It's kind of meta. And this study compared an FASD group with a group of people with mild traumatic brain injury, a group that historically has been tested on these effort tests a lot. And the main finding is that, people with a mild traumatic brain injury perform poorer on these effort tests than are people with FASD, which we don't often get to say a lot, but it's kind of good news for us in terms of assessment, in that we can perhaps start using these effort tests and feel safe in using them and know that we're tapping into effort and not reduced cognitive abilities. All right. This page is summarizing a study that was done in Sweden, I believe. And they did a kind of a national registry and looked at 79 adults with FASD, and mean age is about 32 years old. And they found that compared to the normal population, this group of people with FAS were more likely to receive special education, be unemployed, receive a disability pension, have higher hospital admission rates for both alcohol abuse and psychiatric issues, be prescribed psychotropic drugs, and interestingly, criminal offenses were similar in this study. So we have been citing an American study on long-term outcomes at different ages, and saying, that there's high rates of mental health problems, issues with the education system, dropping out early. We have all these outcomes. This is another study that helps build our case that, people with FASD have difficulties that are long-lasting, and we need to support them throughout their life. So in early childhood, adolescence, and adulthood, because look, we have these issues. So studies like that are very good for helping us build our case around interventions. So unfortunately, there wasn't a ton of intervention research to cover for you, but I think that's because a lot is in process. As Jackie mentioned at the beginning, research takes a long time, and intervention research takes a very, very long time. And we're catching up to you out in the real world. So we have a few studies published in 2014, 2015. I would expect that 2016, 17, 18, hopefully we have way more intervention studies to cover for you. The first one that I want to talk about is the math intervention. If you're interested in this, there's a full Alberta Learning Series video done by Dr. Rasmussen on MILE, so Math Interactive Learning Experience Intervention. In the past, there was studies published describing this intervention and the outcomes. And the new piece that we have to add in 2014-15 is how those researchers took this math intervention that they were delivering in the lab in schools and translated it out into the community. So they're trying to reach youth in other places and train other providers. It was a small sample kind of case study, but it's really good preliminary work in how we can go from this process of developing an intervention, testing it a few times with big groups of kids, training our teachers and getting it well established in schools, and then take what we're learning and teach it to everybody else and get it out there in the real world so we can reach more kids. A big part of the MILE intervention and how they translated it was metacognitive training. And if I were to predict, I think you'll see this a lot in the coming intervention research. Metacognition is basically thinking about your own thinking. So as you're watching me right now, you might be thinking, oh, that's really interesting, I'm engaged in this, I want to look up this MILE study, or you might be thinking about, let's move on to the next thing. So you're just engaged in your own thought process. And if you're one of those people who you don't really care about math interventions, but you want to look engaged, you're saying, okay, try and focus, what can I do to pay attention, things like that. So these are those skills, this tapping into our own brain that we're trying to pass on to our kids with FASD. It might not become quite naturally to them, so we're going to use this existing framework of external brain that you all know about. Let's surround the child with support, help them through things. So now we're adding in this piece where we're a coach for them, we're helping them to think about their thinking, we're helping them to problem solve, things like that. So I think this might be a new wave. It's also a part of the third point there, self-regulation training. If you're interested in this, the specific program in this study, it's called the ALERT program, and it's actually available if you go to FASD conferences. It's always on the Guilford Press or whatever the publishing company is. It's always there. ALERT program, how does your engine run? So that's the program that this third study used. Basically what they did was ran the program in groups for about 12 weeks, topics covering emotion regulation, calming strategies, how do I deal with my anger, how do I get myself in the right place to learn, group skills, managing frustrations with peers, all that kind of stuff. And at the end of the study, they found significant improvements in inhibitory control and social cognition. So basically what that means is impulse control. So they're thinking a little bit before they're acting, doing that a little bit better than they did at the beginning of the study, and their social cognition. So this speaks to that theory of mind piece that I was talking about earlier, stepping into someone else's shoes. They did better on that test after this self-regulation training. So that's really good news. Parents saw improvements too. It wasn't just on our psychological tests in the lab. We had the parents rated them, and they saw improvements as well. In this study, it's really quite large. They also did brain scans, and they saw changes in brain volume. So really, really promising work. This study built on a previous one in 2012, I believe. So it's really important to replicate. So this is the second study on the ALERT program, and it's showing some good results. All right. So switching gears a little bit, we have a youth outreach program, which is really great out there in the community, seeing some positive outcomes in safety, school attendance, sexual health, etc. I'd love to see more of these out there in practice. It's great that we have it in the research saying that we have some positive results. And then totally different is this antioxidants research. This paper, I believe, is a review. So just as you've seen, we have quite a bit of talk about this nutrition, and this one is looking at using nutrition therapeutically. So previously we were talking about how we have deficiencies in moms, and then in deficiencies in diet and nutrients, etc. This paper is looking at using antioxidants to improve functioning. So definitely a new area that we'll probably be seeing more of in the future. All right. A very, very important thing to capture is how our caregivers and how our service providers are feeling out there day to day, how they experience service delivery, etc. We're still seeing that our foster and adoptive families are looking for more support. I think we can always do better. We're always striving for that. Some of the systemic barriers that this study addressed were difficulties stemming from delayed diagnosis, so it's not soon enough, we're not getting in there fast enough, that services aren't out there once you are diagnosed, unfortunately, and then qualifying and getting things, like it can just be a hard experience to go through, so more support the better. Recommendations from this study were that interventions, one, have to be available across the lifespan, so all the way through life, need a prevention focus, be individualized, be comprehensive, and be coordinated across systems. So easy peasy. Am I passing it over to you, Katie? Okay.
Yeah, tag in, tag out. I've been tagged in. So the next, actually the last category of research that we wanted to touch on was this area of prevention. And as Marnie just mentioned in her last slide, a lot of the caregivers and service providers are really highlighting this prevention piece. So a lot of our research is talking about the impairments and the difficulties and the different profile of functioning that our kids and adults have, our kids and adults with FASD. But let's step back and try and talk about efforts to prevent FASD from happening in the first place. Many of you probably know about a couple of studies published last year suggesting that low levels of alcohol consumption were okay during pregnancy. They were not linked with any adverse long-term outcomes. As you might imagine, there was a bit of a strong response from the FASD world in terms of responding to this research and trying to get the message out there in the community that, sure, these two studies found that low levels of alcohol consumption weren't showing up in these studies to be impacting the person long term, but that doesn't mean that it's okay to drink while pregnant, and we want to be very careful about the message that we're sending to the public is accurate, and people are getting the kind of the consensus message rather than these couple of outlier studies. And so one of the studies published in 2014 was a specific response to the research, two studies particularly documenting low levels not having an impact. So there was a commentary on the things that we still need to think about. So pointing out some methodological issues in these studies, pointing out that there still is no safe level of alcohol that we can confirm in the research to consume during pregnancy. There was also actually recently in 2015 a DTI, so that's a particular kind of brain imaging study, done with newborn babies who were prenatally alcohol exposed, and they did look at low levels of alcohol consumption to see what effect that had on the newborn, but those results were kind of inconsistent, they said. There was no consistent pattern associated or identified between low levels of alcohol consumption and newborn functioning. So I think that researchers have been doing this for a long time, talking about low levels and trying to find a safe amount to drink while pregnant. And I think this is still a direction in the research that is going to be pursued for a long time, especially when you have media and public announcements that these low levels are not really having much of an impact. There was a really cool study, I've wondered this myself actually, what about non-alcoholic beer? Because I know that non-alcoholic beverages do have a bit of alcohol in them, and so I've wondered, is it safe to consume those when you're pregnant? I've also heard questions like, can you use hand sanitizer that has ethanol in them when you're pregnant? There's no hand sanitizer study, but there was a non-alcoholic drink study, and they found that because of the level of error that you're allowed when you're labeling these alcoholic beverages or these non-alcoholic beverages, there's actually sometimes a higher level of alcohol in non-alcoholic beer than what is on the label, because the production companies can have some level of error when they're reporting this. So the recommendation of the authors of this study is that don't drink non-alcoholic beer while you're pregnant, because you could be consuming higher levels of alcohol than you realize. And they also touched on this idea of breastfeeding. So there's lots of questions around breastfeeding while drinking as well. And the authors of this research suggested that just as we would do when we're drinking fully alcohol drinks, delay breastfeeding after you have consumed those beverages to make sure that the alcohol gets out of your system. There were a few studies actually across the world, so one in the United States, one in the UK, and one in Australia, tapping into this idea of awareness. So what do people in the public know about FASD and what's being talked about? So one study in the US surveyed college students on their level of knowledge and awareness about FASD, and they found that these college students had adequate knowledge of FASD. So it was a brief questionnaire, but college students had an 85% accuracy rate on these questionnaires, which in my mind is pretty good. I know that just in personally having conversations with people, when I say that what do you do for a living, Katie? Well, I study FASD. What? Like, they don't know what that is. And so I was quite pleased to see that 85% of the college students in the States are aware of it, at least. Because, as you'll see shortly, that their college students, young people, are among the highest risk of drinking while pregnant. So it was good to see that almost all of them, the majority anyways, were aware of FASD. A study in the UK looked at they surveyed, I think, 674 people in the general public in the UK to learn about their understanding of FASD, and they found that, again, the majority had heard of it. They knew what it was. They heard the term FASD, and most of the people who knew about FASD obtained the information from either the media, which is a little bit scary when you think about what's published in the media, or from work, so they had heard about it at work. So I think as researchers, that tells us that we need to do a better job of making our messages publicly accessible and doing a better job at making sure that what's reflected in the media is also reflected in the research. In this UK study, they did a questionnaire about general awareness, but they also did a follow-up focus group to talk to people about where they obtain their information and how, or whether they believe the information that they learn. And they reported that the information that they receive about FASD that they're going to believe in needs to be personally relevant. It needs to there is a need for further education, so they acknowledge that even though they've heard of it, they want to know more about FASD. And they also report a lack of clarity and guidance around how much alcohol you consume while you're pregnant. And again, this isn't surprising given some of the recently published articles about low levels of alcohol consumption. But this is good information, and as Jackie said, and as Marnie has mentioned, this is where we're looking to have the this is where we're looking to drive our research. We're looking to the public, we're looking to caregivers and service providers about what's important and how they will better receive the information that we're finding in the research. So this is really, really important stuff. This last study in Australia was a survey of 100 and something midwives to ask them what kind of conversations they have with their patients about alcohol consumption during pregnancy. And look at that, 93% of them asked pregnant women about their alcohol consumption. Sometimes that's all it takes. Sometimes all it takes is one simple question: do you drink? Or how much do you drink? And I was pleased to see that almost all of them were asking about alcohol consumption. A little bit disappointed to see that only 64% of them actually informed the women about the effects of prenatal alcohol exposure, but I think this tells us that we're getting somewhere. I think we're asking the questions, and there is more work to be done in terms of informing pregnant women and educating pregnant women, and even women who are not yet pregnant, but I think we're getting there. There's been really important research too looking at risk factors for people consuming alcohol or women consuming alcohol during pregnancy, again from across the globe. So there's some research out of South Africa, the States, and in Canada. And these researchers are finding that trauma, women who experience trauma are at greater risk for consuming alcohol. Similarly, in the States, some research have found that women who are abused during pregnancy are less likely to quit and less likely to reduce the amount of alcohol that they consume during the last trimesters of their pregnancy. So this is telling us that we need to support our pregnant women. We need to support our women in general so that they are in a safe place and a secure place that they're able to not drink. Because it's not that women intend to drink while they're pregnant. It's not that women intend to harm their babies, but you can see that traumatic experiences and abusive experiences increase the risk of just having to rely on that alcohol consumption, I guess. So this I found quite interesting, that the study in the United States surveyed women about their risk for having an alcohol-exposed pregnancy. They looked at whether women were sexually active, whether women were drinking, and whether women were having unprotected sex. And so based on those three criteria, they found that 1 in 30, or 3.4% of all women, non-pregnant women, based on those three criteria are actually at risk of having an alcohol-exposed pregnancy. A study out of Alberta, actually, published in 2015, showed, probably not surprisingly, that unintended pregnancy and substance abuse prior to pregnancy increase your risk of having an alcohol-exposed birth. And of course, if you don't know that you're pregnant, then you might not necessarily adjust your drinking patterns. But I think stepping back a little bit, we can say to women, if you could be pregnant, don't drink. Jackie has often talked about this pee on a stick strategy. So if you're a woman who's having sex and who may get pregnant, put a pregnancy test in your purse and just go pee on it before you have a drink. And that's, a pretty simple way of preventing alcohol-exposed pregnancies. This last study came out of the U.S., and it's really important in terms of what motivates people, or what factors influence a woman's decision to drink while pregnant. And these researchers showed that what women believe about other women's alcohol consumption patterns really influences what they're willing to do. So if you have a friend who drank while she was pregnant and her baby is okay, that message carries a lot of weight. And so I think women who are watching other women's behavior, that's how they determine whether they're going to drink or not. And also the level of depression and the level of how functional that woman is will also influence a woman's risk for drinking. And back to Marnie. Tag you back in.
Okay. So I'm going to talk about some maternal drinking patterns. And these next few studies, they're not meant to wag your finger at these women who are drinking, but they're meant to inform researchers and clinicians and practitioners who are developing and delivering prevention efforts. So who do we need to help, really, I think is what it boils down to. So I have a review paper the bottom point there. This paper looked at tons and tons of references out there and boiled it down to 15 papers, and they found these key factors that were associated with mothers of children with FASD. So those are listed there, being older at the age of birth of the child that was later diagnosed, lower education, family with alcohol abuse, other children with FASD, little prenatal care, alcohol consumption before, during, after pregnancy. So these are some of those risk factors. Kind of repeats what Katie's saying, but kind of help key us in to what we need to be looking at, where our social services need to be aimed, and where we deliver our prevention efforts. One other study looking at the maternal risk factors, this was determinants of whether a woman was likely to reduce or quit drinking during pregnancy. So this was a survey of over 300,000 women in the States. And here's some stats for you in case you're stats hungry. 50% drank alcohol before pregnancy. 87% quit drinking during pregnancy. And 6.6% reduced, and 6.4% reported no reduction. Then they looked at some trends in this data and found that it was the older women with higher education in this sample who were more likely to reduce rather than quit. And then they also found that women who were Black or Hispanic or had previous children, they were the ones who were more likely to quit than to reduce. So these kind of studies are what our people who are doing, say, prevention conversation are looking at to inform their practice. We have a couple new papers on prevention advertising. And one of them is kind of talking about the messages in our advertising. And what they're concluding is that you need to combine threat appeal and self-efficacy to promote women's intentions to abstain from drinking while pregnant. What does that mean? I didn't really understand what the threat appeal meant. So what they're saying is your messages need to have good persuasive potential. They need to balance the positive and negative emotional responses. So we don't just want that negative picture of, say, the baby drinking in the belly. We need to combine positive and negative, and that this combination will help us to not get a defensive response or unintended consequences. So just some food for thought there around our advertising people. In terms of an intervention, we found an article talking about motivational interviewing, which is a key piece in some of our prevention efforts. And this study actually found that the motivational interviewing in their study wasn't effective. But the key here, as we often have in studies, is that they had a lot of low-level drinkers. So if you're only drinking, say, 1 glass of wine a week or every 2 weeks, then it's going to be pretty hard to see a significant decrease because you're not drinking very much to start with. So this is one of those cases where we don't want the media running with this story saying that our motivational interviewing efforts don't work. Well, it's just that we're finding they're not working so well with low-level drinkers. We don't have that data yet on our moderate or high-level drinkers and all sorts of other factors. So it's just one piece of the puzzle. Another big piece of the Alberta and Canada puzzle is the PCAP program, so Parent-Child Assistance Program. And this was a 2015 nice and recent paper, just talking about the PCAP program. If you're, looking for a paper to cite, saying that it's cost effective, so matching a mentor with a woman who's at risk, and that the priority in these programs, you want to combine, reducing the alcohol use, plus providing effective contraception. So, Katie's chat about the pee on the stick, but also our other true contraceptive birth control methods. They're finding that the PCAP program, when you combine those two, it creates a solid foundation. I think Katie mentioned something about unintended pregnancy is one of the risk factors to having a child with an FASD. And there's a nice commentary on this discussion and how we need to focus some of our efforts on this prevention of unintended pregnancy, not just prevention of drinking during pregnancy. So it's kind of like a step back, a little bit, standing back, looking at the big picture. So there's a nice commentary there. Lastly, we have just a couple small studies on some interventions out there. Brief training for nurses. Did a good job increasing FASD knowledge, confidence, and resource utilization. So we need to be looking at all our service providers. Here's one looking at nurses. A key conclusion from that study was that the colleagues and the organization needs to believe in and support the message of no drinking during pregnancy for the nurses to, go forth and advocate and talk with their patients about this information. So they need that backing from their work community. Another quick study just looked at the question of binge drinking. So, going out and having, I'm not sure what the exact number is, but 4 or 5 or more drinks at one time, say, Friday night or something like that. And this single question identified 99% of women at risk for having a pregnancy. That was in Russia. And lastly, a very 2015 type of study on a texting program called Text for Baby. It's a service for pregnant and postpartum women, checking in, how are you doing, those kinds of things, and found treatment effects. The more times that they were contacted, the better outcomes of reduced drinking. So I think a very 21st century type of intervention approach that we'll probably see more of. I'm going to leave us there. Jackie's going to step in and talk to us about what all of this means, and we'll have some good discussion.
Okay. I haven't got tagged in for a while. It's because I'm a little older than them and I move a little slower, so I rely on the youth and vitality there. Aren't they awesome? I love my kids. I call them my kids. I'm not sure how cool that is to them, but I feel proud. Anyway, that's a fantastic amount of information. And I don't know about all yous out there, but I listen to all that, and part of me gets really excited to say there's a lot of research going on, there's some neat things happening, this is fantastic. And part of me says, yeah, that's just a lot of information. I'm kind of on overload. What's the point here, Jackie? And how do I use this and take this somewhere? Because that's a lot of stuff. There really is. There's great growth in our field of FASD research. You go back to even when I started in this field, which it was 1 or 2 or 15 years ago or so, and the number of articles we see published every year has grown astronomically. It really has changed a lot. And that's exciting because it tells us that people are interested, people are looking, and people are paying attention. Sometimes it's kind of scary because we start to really see what numbers we're dealing with and what the reality and the scope of this issue truly are. And the more we get that information, the more daunting and overwhelming the problem becomes. And it's easy to sort of feel almost trapped in that. But I see it as really exciting, because I think that we get interested in things that we think we can get behind. If we think this is something to despair and forget it, these numbers are getting higher. Every time I look at an incidence or a prevalence number these ladies presented, it gets bigger as we get better at measuring and understanding what we're looking at. I think that this persistence and this interest in studying and monitoring and looking at this reflects our own hope and passion for this field. We're looking at it and we're examining it and we're studying it because we believe in our ability, working together, to make a difference and to change what's happening here. And sometimes it feels like we're still on the upward slope and we haven't quite got where we're going, but we're moving. And it is a journey, and we're on it together. So when I listen to all of this, I sometimes have these moments where I go, oh man, can we someday get those numbers to start going down, because we're working our tails off. And eventually we'll get there, but we first have to know what we're dealing with. And we have to have an accurate sense of what's really going on out there before we can start accurately measuring any kind of decline. I think just another kind of broad strokes comment I have when I listen to this too is, and I don't know where all our sites are today that are listening to us, but I think something that's really exciting is, and the ladies mentioned a little bit of this, but how much of this research is coming out of Canada, and how much of this research is informed by programs that are ongoing in Canada right now. So those of you who are doing this work in the field are truly informing the kind of stuff that we're publishing right now, really shaping the face of a lot of the research that's happening out there right now. And in Canada, we're really fortunate because we have some really nice partnerships between folks who are providing services in the community, between researchers who are trying to kind of gather that evidence to support the work you guys are doing and help us kind of move it along. But we also have some tremendous support from policymakers and folks who make things like these kinds of presentations possible and funding the kinds of initiatives that go forward. We're fortunate to have government that says, you know what, FASD is on the table. And without those kinds of supporters, we get stuck. And the fact that we're all able to sit at a table and have conversations together, I think, is something that in Canada is really unique. Of course, as you heard at the beginning in the introductions, and some of you may know, I work with the Canada FASD Research Network, and really encourage, if for some of you this is new and you're like, the Canada what? It's the Canada FASD Research Network. I have not got a slide to put up, and I'm sorry. Normally I do. I really normally have slides, but if you want to just put that in your Google browser, Canada FASD Research Network, what it'll do is take you to our home site, which will link you to a lot of prevention, intervention, and diagnostic work that's going on in the country right now, both in terms of research and practice, also a lot of discussion around links to policy and what we're seeing happening in governments, in legislation that's being developed. There's a lot of conversation right now around criminal code or legal initiatives that are happening in the country. So that's just sort of a sidebar. Maybe it's just a plug, a Jackie plug there. But I think it's just an example of what Canada has done that's really unique, that says we want to have people have this ongoing conversation. There's resources. There's a site to go to. It'll link you to a bazillion other sites. But it's to keep us all on the same page. Because it's hard to stay on top of it. It's hard to stay connected to it all. We do what we can to get the information out, but it's difficult. And I think the more that, if you can have a couple of bookmarks in your browser, take you a few sites. We have a couple of blogs. Sometimes blogs are nice for those of you if you're not getting overwhelmed, because it's going to bring you to some of the current research. So just to kind of say, hey, here's some ways I can keep up on this, they're out there. And again, at the Yay Canada. I feel like I should start singing the national anthem right now. I'm in orange though, not red. Oh well. Anyway, I just think that's something to be really proud of for all of us, that we've really seen that national partnership emerging to allow us to respond to this need. So before I'd like to talk about a few highlights. The ladies provided you guys with tremendous detail and some fantastic study information. I have a handful of things I just want to come back to as things that to me really resonate. But before I do that, I want to ask if there are questions. I'll get to my points, don't worry. I always find ways to get my opinion in, believe me. But I just want to see if there's some questions first, because I invited you guys to throw in questions to begin with. And they could be in the room. There are people here in the room. I keep talking, to everyone on the camera, and I'm neglecting the room here too. So anyone who has any questions, let me know.
I have a question.
Yes, yay. I love questions. Here's a mic. You even get to talk into the mic.
Based on the research that you shared, it seems like there's a focus on the whole spectrum in terms of alcohol consumption. You talk about really low levels and how there's even some dispute as to what level is risky. But then also people with serious addictions who are probably drinking throughout their pregnancy. And I wondered, is there work on the research side to focus, maybe it's even the definition of FASD or the target groups, and prioritize our work?
Absolutely. Depending on the studies, and we're going back beyond the year, and these ladies will correct me when I say something wrong, but different studies use different information to characterize the group that they're working with. In some studies, they have the luxury of compiling a lot of information around maternal alcohol use. And so there are a number of studies, particularly I think both ladies actually talked a little bit about the profiles and some of the sort of the profile, or what an individual with an FASD may present with in terms of characteristics and features. And there are a number of articles out that look at those sort of features of FASD and speak to how much alcohol consumption there was. A lot of the early studies in particular, and some of the seminal ones, and by seminal I mean sort of the ones that kind of set the foundation for the work we do, looked at women who had high levels of alcohol consumption. And so early work was really focused on high risk and high alcohol consumption, because it was the characteristic that was most able to differentiate, recognize the group. And even helped with diagnosis. Diagnosis is easier when there's a lot of alcohol. As we move forward, some of the distinctions are getting a little subtle, and there are groups that are saying, well, let's look at low use, moderate use, and high use. So different studies will kind of refer to those pieces. Of course, being the research world, heaven forbid we ever really work well together. So do we define them the same way? Not always. And so often what we do, even when we look at research and when we talk about it, is we try to say, okay, well, they say moderate, that's the same as their high, or their moderate's the same as their low. So we're not even all using the same criteria. So we're a long ways off of doing that really well. One of the things we know is, or we think we know, and some of this comes out of the animal work. Animal work is great because we can control for everything. It's not great because the brains are simpler than ours. So we need to do both, but it does help us. One of the things the animal work in particular has told us is that in general, more alcohol leads to greater problems. So the greater the alcohol exposure, the greater the problems, to the point where we look at death of that embryo or that fetus. And so in population levels, we know more is worse. However, other work has revealed to us that it's not always that simple, particularly when we start looking at human beings. So generally speaking, we can say more alcohol isn't great, but we also are starting to understand that patterns of alcohol use have an effect. So whether I'm a chronic user who drinks the same amount every day all the time, or a binge user, and you heard the ladies reference binge drinking a little bit, which means I only drink on the weekends and then I really go for it. And really go for it depends on a few things, like if you're my size or if you're 6'5" and whatever, it means a few different things. But generally when we say about 5 alcohol drinks in a sitting, you're looking at a binge episode. Some of the work that we look at now tells us that binge drinking patterns result in greater problems, or can, as in groups, than chronic drinking every day all the time. Are all of our studies characterized by these things? No. Well, why, Jackie? Why not? Well, we often don't have maternal drinking patterns to look at. So where we do have them, we've gained that kind of knowledge. But a lot of research, even research where we're looking at how we diagnose and groups that are already diagnosed, we may not have access to moms to tell us about their drinking history. So there are some studies out there where we're able to start refining our understanding, but we're a ways away from that really. The learning is growing, but a lot of the work these guys talked about, will not necessarily say these were the drinking levels of mom because they may not have had that. Is that fair to say? They're nodding. Good. Phew. Nobody's throwing anything at me. There's no good. They usually clear their throat or start shuffling when I say something wrong. So if you happen to notice that.
The other thing about it too is that it's not, alcohol consumption is not the only factor that will impact a child's development, right? So that's why a lot of the things we're looking at is like maternal nutrition or prenatal care or other things that happen during.
So Katie, I'm going to interrupt her because I don't know if you guys can hear her, but what Katie is wisely saying, jump up here if you want to add, but what Katie is wisely adding is that there are a number of other variables, maternal variables, that contribute to the effect of alcohol. So maternal nutrition, maternal level of stress, and just general health are all factors that change the way the alcohol might affect that developing embryo or fetus. The more vulnerable mom is, the more vulnerable fetus is a general rule of thumb, although it's complex. We're complex. Bottom line, the more you drink, the worse it tends to get, and binge drinking really stands out. Does that sort of answer the question? Cool, awesome question. Yeah, it's a big one. The whole issue of how much is safe, and the issue of alcohol is a huge one. And Katie and Barney both talked about prevention at the end of the presentation in terms of research. It's a really tough one. It's a tough one. There's so many factors that contribute to what we understand about how much alcohol, if any, is safe. In Canada, the Canadian Medical Association says there's no known safe amount of alcohol. That's sort of our operating principle. If you're pregnant or thinking of becoming pregnant, don't drink, are sort of our general health principles in Canada, which I may or may not be misquoting slightly, but they're along those lines. But the researchers haven't yet agreed that is there a point, is there levels, there's, scientists sometimes put on their hat and forget that there's a real world out there, and we start to dicker about, well, what about this versus that? And it becomes this interesting little intellectual debate, when at the end of the day, we're saying, how do we keep women healthy? Like, let's just get back to, there's a risk if you drink, so how do I support you to be healthy and feel good, and, those kind of messages. Jean.
Hi. I'm wondering if there are any longitudinal studies related to intervention, effective interventions that are happening right now.
Are there longitudinal studies? There are studies coming. Longitudinal studies are studies over time, so we can not only say does an intervention effort work, but does it work over time. The best longitudinal stuff that's published so far was already referred to, I don't remember which one you guys said, maybe Marnie, was that MATH, the Mile Interactive Learning Experience, in that they did a follow-up after 6 months with the kids and found that it retained, that's it. I know, Jean's like, that's not much, Jackie. No, it's not. Alert did, the self-regulation did a 12-week follow-up. So when we're saying longitudinal with intervention right now, that's the best we're doing. Now, we have done some work with programs that are longer. So, for example, some work that we've done here in Edmonton, where we've looked at mentoring programs for youth with adolescents with an FASD, have been a little bit longer term in that the program is a 3-year program. So we follow the kids through the program. But beyond that, hard to get. So huge deficit in terms of how do we follow it up. Some of what we've tried doing is some cross-sectional work to sort of see impacts over time with different groups with naturally occurring supports. So we look at kids, for example, who have an early diagnosis compared to those who don't. How does that change their access to services? And then we do follow-up with them that way. We're looking at approaches where we can bring kids back in for follow-up assessment work and look at what their access to services and supports were. So we can look at how having that community response, basically in 1996 and forward, Anne Streisguth started telling us that if we diagnose kids younger, it's better. Because the younger they are, the sooner we get supports in, the better the outcomes. That was sort of a conclusion that came out of her cohort work. longitudinal, but not intervention specific, but just trying to track them over time to see what happens. And those were some conclusions that she drew based on that work. We're trying to replicate that here, but that's not specific intervention research. That's sort of looking at how are the natural existing services and supports changing trajectory. So it does reflect, sort of in a passive way on how or what are the things we're doing in the community helping, which is really important. But in terms of when we actually study, let's see if we do this, does it change the brain in this way? Jean, we're a long ways off. And part of it is it's time consuming, and part of it, bottom line, is it comes down to dollars and cents. It's very expensive. To get the kind of numbers that you need to actually say, does an intervention work? And get the number of staff that you have to do to say, how can I prove it works? Because we always have to prove these things. Even if we work in the community and we say, well, I know it works, if we want to then say, we want somebody to invest a lot of money in a program, they want proof, they want evidence. They want us to say, here's the science. And to gather that kind of scientific, it costs. And then to say, well, we tested these guys 5 years ago, we want to see if this intervention is still holding, it's a challenge to get that funding. It really is. And there's actually some cool partnerships, again, going back to, speak to the wonderful partnerships that exist in Canada, where a lot of programs are really trying to do this within their programs. And they're saying, we want to monitor and track outcomes in our programs. You guys heard mention of PCAP. And those of you, there might be people listening right now that are part of PCAP programs. And Therese Grant, who started that in Washington, and the folks who are implementing it here in Alberta are doing a fantastic job of saying we want to start tracking things a bit more over time. But how well do we follow people outside of programs? We're still struggling with that. How do we keep them once they're out of our programs? So 5 years post-program, is it still there, or do they have to come back in our program? That's where we're really kind of falling short. So, hey, if anyone out there is thinking, gee, we want to do some of this, let me know. No, maybe not. Let these guys know. They have time. Are there any other questions? Oh, she's nodding, and her eyes are rolling back in her head in some kind of, look out way. Oh, I'm so excited.
Yeah, there's lots of good questions coming in.
Fantastic.
I just want to remind everybody who's asking questions to please include your email address so that we can send you a response if we don't get to your question today. So if you've asked a question already, maybe just send us your email address and where you're located. Okay, so I'm going to start at the bottom. So this question is from Medicine Hat, and the question is, can you please explain more as to what you mean by gender differences in the cognitive profile? And I believe that's when Katie was talking near the beginning of the presentation, so I don't know if Katie wants to speak to that.
You have to come up here. Come up here, they can't hear you.
If the question is about gender differences in general, that just means that males and females show different pattern of functioning in that particular study. And if the question is about what particular pattern was present in males and what particular pattern was present in females, I don't know off the top of my head, but I can find out.
Okay. So Katie is going to respond with that specific information to that individual. Cool.
And the next question I have is, with the Mile and Alert programs, did the gains persist after the programs ended?
And that sounds a lot like Jean's question. And as we said, with the Mile, the math program, we know what they did for 6 months. With the Alert, we know what they did for 12 weeks. So there's some persist. So, the question we want to know is, let's go back every year and find out if they stick. It's a very important question. We don't know yet.
What types of therapeutic processes do you find work best when counseling individuals with an FASD?
That's a great question. I'm not a counselor. I have done a little bit of work with counselors. There's some research out there that talks a little bit. There's not a really, that was a convoluted sentence. There's not a lot of good evidence-based data that speaks to our outcomes are better with this approach versus a different approach. I'm looking at the girls just to see if they kind of go like this as I'm talking. But we generally tend to speak to approaches that are a little bit more flexible and adaptive. That's more of and that is some of what I think they refer to with some of the research, but one of the things that comes often out of counseling settings is that there'll be missed appointments or difficulty working to the existing schedule. And unfortunately, a large number of organizations, in order just to continue to function and to protect therapist time, say if you miss this many appointments, you no longer get service. And that's a big challenge for our population. So we find that a lot of times they are blacklisted or removed from service delivery from certain organizations because sometimes we need to be a little bit flexible. And depending on the level of functioning of that individual, they may show up the wrong day, the wrong time. Then how do we do that? How do we respond? It becomes a real tension question between how do we appropriately allocate resources and time, and how do we also kind of meet the needs of this population who who sometimes really struggle with schedule, time awareness, getting where they need to when they need to be there. Some of the approaches that we've certainly talked about are often much more pragmatic approaches, so a little less insight-based, a little bit more of what do I next do, what's a solution to this problem, next time I am faced with this issue, how might I respond differently, and practice. Role play. I'm going to practice that over and over and over again so that I do that next time. Less of what we call a cognitive behavioral strategy, where we spend a whole lot of time reflecting on, well, what triggered you and what set you off, because oftentimes this is a population who won't know. Marnie talked, I think, about a metacognitive strategy. We do a little bit of, let's think about what we're thinking about, but often it's going forward to help us develop strategies. So if I know that every time I'm here I want to pick up a drink, how do I keep going here? Not why do I pick up the drink, but how can I not go there? So they're a little bit more solution focused that we can engage folks in. I'm trying to think. Mentorship-based practice, yeah, thanks Marnie, is often something, and again, I know that's not a traditional counseling approach, but we do look at work that says, how do you best use a mentor? How do you work and talk to folks? Who's safe to talk to? Really, adaptability and flexibility is crucial. There is so much variation and range within the FASD population that you need to be aware of what is the level of functioning, what is the level of ability, what is the support system this particular person has, how can I work with their support system to support them, how can I work with an individual in a way that's meaningful for them. I often say when I work with a counselor who's working with a client, I say, you know what, look for your evidence. If this person is able to come to a counseling session with you, work on something with you, and then you later hear back that they were able to apply that, good. If they weren't, then you as the counselor may want to go back and say, okay, maybe I need to revamp my approach as opposed to asking my client to change the way they're doing things. So I think sometimes as professionals, we have to ask ourselves, we want to keep the folks we're working with accountable to a reasonable level, but I think we have to keep ourselves accountable. And traditional counseling approaches may not be the best way to go. And we need to be looking in the mirror a fair bit to say, if this isn't working, what can I do differently? You're welcome.
So the next few questions are just requests for some of the articles or a reference list for the studies you were talking about, and they've included their email addresses, so you can just follow up with them.
That's perfect. Thanks. Yeah, those will get out to you all.
Yeah, great. So the next question comes from Edmonton, and the question is, how do I go about getting a diagnosis for a child at the Glenrose? Do I need to be referred by a family doctor? FASD talks about the effects regarding alcohol use. What about other assorted drugs used during pregnancy, and how greater are the problems?
Okay, so I'm hearing two questions. So one is about getting the diagnosis at Glenrose. I'm not sure if they're doing doctor referral right now. They generally do. And if you've got a physician involved in the child's care, they can contact the Glenrose for access to the assessment services. They do need to know that there's confirmed prenatal alcohol exposure to get an assessment through the clinic at the Glenrose. If in the absence of that, there are other assessment clinics at the Glenrose that they may be streamed into. So when there's prenatal alcohol exposure, they'll get to the FASD clinic. When there's not, then they will get to one of the school-age neurodevelopmental assessment clinics or those kinds of programs. So there are services either way. I have no idea what the wait list is like right now. wait lists. We can go back to the issue of service accessibility and challenges like that. But that's, I believe, still the current way to access the Glenrose assessment services. The second question, I believe, was around use of other substances during pregnancy. And you heard a little bit of mention of how exposure to other substances, say tobacco, may increase the likelihood of attentional or hyperactivity type symptoms. And that's the truth with a large number of other drug exposures. One of the things we have found absolutely is we're sort of talking about how great the risk gets and how big the impact gets. And the more things you throw into the bucket, the more the likelihood that the problem is going to get worse. But when we look at an even playing field, again, we'll look at the poor animals who devote themselves to the study of this field. We know that above and beyond anything else, alcohol has by far the greatest impact on the development of the brain and body, for that matter. So it's hands down the greatest one. We look at things like cocaine, we look at things like heroin, and you're better off doing heroin during pregnancy than drinking alcohol. Yeah, I'm not saying to use heroin. Here we're going back to media quotes. I could just see this coming out now. And Jackie said to every woman, use, yeah. No, I am not saying that. But I offer it up because it is shocking. It's shocking to me when I hear that, because I think, wow, that's really a destructive drug. But in terms of the actual science and the toxic effects of the alcohol is really toxic. There is some study coming out now looking at crystal meth, and there seem to be has some really significant impacts of crystal meth as well. I haven't seen the most recent stuff, but that might be something that we start hearing a bit more about as we go forward. But regardless, alcohol tops the list. So, we're talking about a legally accessible drug, and it's really very significant. Yeah. Is that good? You got more?
Oh, yeah, there's more.
Okay, well, why don't I add a couple of my thoughts very quickly, and then we'll come back to more questions, because I love questions. Then it's what you guys want to know, and not what I want to say, so we're trying to balance. A couple of things I did want to just highlight based on the presentation from these ladies and draw attention to was, again, to reiterate something I said at the very beginning, and we continue to say, but please note how practice-informed the research is. What you guys do out there is mattering, and I hope you see that in some of the research. There's some tensions that exist in the research world, just like the practice world. Issues of ethics, issues about what's right to do, what's wrong to do. How do we work best with women? How do we support women? What messages are important? Whether or not we can study poo are big questions. And, we joke about it a little bit sometimes when we talk about the study of poo. But there are huge ethical issues because we're often experiencing some tension between mom's rights and baby's rights. And it becomes a real difficult discussion. And, when the ladies were talking a little bit about prevention initiatives, and we're saying, we need the messaging that goes out to be clear and to speak clearly of risk. But really, a lot of what we're trying to do right now is to also speak very clearly about support and what support can look like and what it means to strengthen women, strengthen communities, and strengthen children. And so one of the things you might start seeing, and it sort of came out in some of the work that these girls work to, is that we're really looking at not just talking about what not to do, but beginning to talk about what to do. How to teach people to use contraceptives. Not just don't drink, but here's how to use contraceptives. Here's what to do when you're pregnant. Here's somebody you can text when you're pregnant so you can talk to somebody. You're not alone when you're pregnant, because pregnancy is tough. And if you're already under a lot of pressure, and we talked about some of the risk factors, and you feel alone, it's hard. So instead of saying don't drink and take away the only other thing that they have to escape their reality, why don't we provide something else, an alternative? So there's new work continuously emerging that's having us start thinking about what can we do? What can we do in terms of intervention? What can we do in terms of prevention, in terms of support? How do we strengthen communities? How do we strengthen individuals, whether they be mothers or individuals with an FASD? The intervention work that we talked about a little bit, some of it speaks to how do we support mentors and support systems like PCAP. Some of it also spoke about the fact that we can strengthen the individual themselves. Intervention can be direct. It can target individuals. People with an FASD may struggle and they may have impairment, but they can still change, learn, grow, and develop. So our initiatives can be both individual and community-based. This is exciting stuff, I think, and it gives us tremendous potential and opportunity as we go forward. I think that we talked a little bit about, I know one thing I want to say, you heard mention about the cortisol stuff. That's really cool stuff. That's that stress hormone. I like this stuff because it's really exciting. But one thing that didn't come out of, and you're going to hear more about this, and I know I hear this question all the time, so I'm going to go to it even if it doesn't come up as a question, is around sleep. And the fact that kids with an FASD, do they not sleep well? What's going on? Sleep patterns are a real problem. When you don't sleep well, you're more owly the next day and things just sort of deteriorate. And that's through the lifespan. I mean, I say kids, but it's through the lifespan. And some of this cortisol work, this is sort of a great place where the hard science meets the real world really well, I think, because it tells us, all of us, we have these stress hormones, and we all have them in normal amounts day to day, right? We got to, it keeps us going. It's our adrenaline. It's what gets me standing up here in front of you, right? It gives me the energy to talk nonstop. And when we wake up in the morning, our cortisol is the highest it'll be all day, and it should be, because it's got to get us juiced up so we can actually get out of bed, get going, and face our day. Our cortisol is lowest before we go to bed, or thereabouts, because it needs to wind down. We have to wind down and be able to lie down and go to sleep and not lie there going like, oh. And if you're lying there ever having that night where you're kind of vibrating and you can't get to sleep, it means your cortisol is probably still a little too high and you haven't wound down enough. That's why we do a lot of relaxation stuff to help people wind down at night, so we can bring that chemistry back down a bit, get that stress declined. When we looked at the kids with FASD, we found morning cortisol, too low, evening, too high. Guess what that means? Hard to get up in the morning, hard to put to bed at night. Really important, because now we say, we've seen this, like this is something that people, parents, caregivers, teachers in schools, people talk about this often. Cannot get this kid going in the morning and cannot get this kid to bed at night. Why? One reason seems to be the way the stress hormone works in the brain. All right, well, that's great to know. Now what, Jackie? Well, you know what? Now we can start looking at intervention that helps us deal with cortisol. So maybe if we know we need to elevate in the morning and we need to reduce in the night, we can start doing more physiological or body-based interventions that actually help us regulate cortisol. So in the morning, that means I want to try to get somebody moving a bit more and recognize it's going to take them longer to get going in the morning. It's not because they're lazy, it's not because they don't want to do it, it's because their chemistry is a little off in the morning, so we need to give them stuff to kind of get them jigging up in the morning, right? So that's a good time to put on the dance videos, or say, you know, when you say no video games before you go to school, maybe it's a good time to have a little video action. One of those dance party ones where you have to kind of get your body, okay, I won't dance anymore for you. See, I am staying behind the thing though. But we need to get that cortisol up. At night, it's too high. So it's not that I don't want to go to bed, it's not that I'm ignoring you, it's not that I'm not trying to sleep, it's that my body is vibrating. So what do? Well, I take an hour before bed, and I do self-soothing. I do relaxation activities. I don't run. I don't be active. I do stretching things. I, look at stuff like yoga or Tai Chi for kids. These are great things that help us re-regulate and down-regulate. In the morning, I got to up it. In the evening, I got to down it. Cortisol stuff tells us that. So the science has kind of told us that one of the reasons, and there's probably lots of them because we're complex human beings, but one of the reasons you guys are seeing that effect is brain chemistry. So let's try to play with the chemistry. Let's do things that do that and not just think that they're choosing to behave like this. So it gives us different options. I think that, you heard a lot about the variety, and I think you heard a lot about the fact that folks are complex. We talk about profile. Our profiles are getting a bit more detailed in terms of the kinds of issues that we might see in FASD, but they're not always that helpful at an individual level. If you're working in a community, there's 20 things that could be going on for this individual, but at the end of the day, that individuals might look different than the one next to them. So we look at those profiles to kind of inform us, to give us some questions to ask, but they're not going to tell you about the person that's right in front of you. But they might give you questions to ask. One thing I thought was interesting, and this will be a last note, and then maybe we'll have time for another question before we wrap up, but is listening to these ladies talk, I saw the way our research between things is starting to kind of connect. So when we look in the profile research, I'm hearing things like disinhibited, which kind of means I have no brake pedal. I'm always on the accelerator. I'm always moving forward. So one of the things we often see with FASD is they've got no brake pedal. And then I hear stuff about puberty, and I hear, hey, there's higher testosterone in puberty. And then I hear things like, ooh, there's more risky sexual behaviors. And I'm like, okay, no brake pedal, lots of testosterone. Yeah, I'm sure there's a lot more risky sexual behavior. So how does that understanding change? Maybe I don't just need to teach sex ed, maybe I need to teach how to find a brake pedal, or how to drive up hills so I can slow the vehicle down a bit more because the brake pedal's not working. Maybe I have to rethink the way I'm doing training, because it may not be that you don't have knowledge around sexual education or safe sex, but rather you got no brake pedal. When you're in the heat of the moment, it's gone. You got high testosterone, you're ready to go. And so as we start putting these things together, I say, wow, and then I hear about a program like Alert. How does your engine run? And I think, wow, maybe we can use programs like that to help us learn how to inhibit, and that's going to change that risky sexual behavior better than specific programs, or at least it will be a nice complement to other education things. So we can do a brain train while we also increase sort of strategy. So I thought that was exciting. I think we're starting to put pieces together to help us use that science to continue to advance our practice. Do we have time for another question? Or did I tap us right out?
Sure, we've got about 9 minutes left. I'll throw it out there, maybe just...
I was going to say give me a quickie, but then I thought on the end of that conversation, maybe that was a little inappropriate. But, oh, now people are shaking their heads. That means the line's behind me. My bad.
Advocacy is happening with the Ministry of Health and the Ministry of Children and Youth Services across Canada?
Oh, man, I don't know. That's an awesome question. What kind of advocacy is going on? I mean, there's a lot of grassroots stuff for people trying to speak up. I don't know of formal advocacy. I know there are champions that often try to speak up for FASD. I know, as I've already plugged, the Canada FASD Research Network, we often try to put briefs together and briefing papers to different ministries and different governments to provide some advocacy. But I don't know that there's any coordinated initiatives. There is, with the Public Health Agency of Canada, there's an FASD initiatives person, so there is a person that works within PHAC to try to advance sort of national health initiatives, but I don't know of if there's a coordinated formal approach. I think it's an awesome idea. I think if there's those of you listening saying, gee, I really want more of this, send us emails and help us write policy briefs. Yeah. Oh, we have insight?
I work for the government of Alberta, so I can add
Awesome.
that we have the 10-year strategic plan. This is part of it, and we're going into year 8. So we're coming up on the end of it, but this plan offers prevention, awareness, and support, and it funds the service networks all over the province. And I know they're a partner of the Canada FASD network that you mentioned, and really partnering with them to share best practices.
Yeah, fantastic. And I know BC has a strategic plan as well. If there's anyone, I don't know if we have BCers on board or not today. Ontario's developing one right now. Manitoba has one as well. If you're not in Alberta, other provinces tend to have them, and those are also great places to look to in order to tap into those advocacy pieces.
Our email, if you flip forward 2 slides, our emails are on there.
Oh, there's our emails, by the way, if you don't already have access. Oh, there, thank you. And it should be on the handouts you guys got anyway. I think you'll have our emails on the handouts too. Cool. Did we take it right to the wire? Yeah. Well, I can really do that. I was trying to rein it in too. That was, what can I say? Take me over? Oh, are we done? Okay. Yeah. Thanks very much, everyone.
Awesome, thank you. Yay.
There's nobody here. There's nobody here, not that nobody's clapping.
Yeah, so everybody is clapping, I'm sure. from the webcast at their computers. So thank you all for the great presentation. It was really engaging and interesting, and we all learned a lot about the awesome new research that's coming out. So for everyone watching, thank you all please note that evaluations will be emailed to participants within the next 2 business days. So please be sure to sign the attendance sheet, and you've all signed in, so that's great. Your feedback on the session is very important to us. And so this presentation concludes the FASD Learning Series for 2014 and 15. We humbly thank you for your support, interest, and feedback into this year's learning series. It's been a wonderful experience, and we're grateful to everyone involved in making it possible. We'd especially like to thank the presenters for generously sharing their knowledge and experience with us. And finally, thank you to the technicians for getting us through the year relatively glitch-free. So everybody, please stay tuned for updates. Future, so be sure to visit fasd.alberta.ca to stay informed. Thank you, everybody.